All right, cervical radiculopathy. Who here has had a cervical radiculopathy? Oh, even I think there are more hands for that than for the neck pain. Although I think my question was who has neck pain right now. So my talk, I'm going to go over the myotome, dermatome, and sclerotome, discuss an algorithm for approaching radiculopathy, discuss a differential diagnosis, and discuss the exam a little bit and go over a few cases. So neck pain, as I said, is very common. Cervical radiculopathy is also very common, but a little bit less so. But still, the annual incidence is about 100 per 100,000, which to me sounds actually a little bit low. But there you have it. The peak is in the 50s, and the natural history of cervical radiculopathy is overall favorable, as it is for axial neck pain. So this slide shows the dermatome on the right, and then a bunch of muscles in the center, and then the skeleton, of course, well, on the right. Let's just take a C6 radiculopathy. Now there are these little shaded areas that show you the dermatome, and you can see how the dermatome doesn't match up perfectly with the myotome. So it's more, the C6 muscles are sort of upper arm and shoulder muscles. And on the far right is the C6 sclerotome. The bony, shows the bony innervation of C6. As I discussed in the prior talk, all of these things share a common origin. They start off as somites, and those somites are innervated early on in development, and then the tissues migrate. And oddly, particularly in the upper limbs, the migration leads to different things ending up in different places, and it's the sort of the differences in the sclerotome versus the dermatome that account for some of the kind of the funny referred pain patterns that you see with cervical radiculopathy. So for example, a patient with a C7 radiculopathy may have pain at the inferior angle of the scapula. Now, there are no C7 innervated muscles there, really. I mean, latissimus dorsi is kind of close, but not really right there. Also, so a C8 radiculopathy, those patients may present with elbow pain. And as a matter of fact, it's a common referral that patients come in with numbness in their little finger. And if a patient complains of numbness in the little finger and prominent elbow pain, well, often the referring doctor says, well, this is an ulnar neuropathy because there's pain at the elbow. But I tend to generally think that ulnar neuropathy, those patients don't have pain at the elbow. And if they do have pain, I tend to think it's more likely to be a cervical radiculopathy. Although some patients with ulnar neuropathy do have pain at the elbow, so there are exceptions to everything. So this is an algorithm for approaching neck pain. Cervical radiculopathy. These patients should have a component of arm pain or arm symptoms. So kind of going through this, the first question is whether or not there is a neurological deficit or a high risk for infection or neoplasm. These are sort of the red flags, and those patients should get an imaging study, probably an MRI scan, and depending on the differential diagnosis, CSF analysis and other laboratory testing may be needed. And if the answer is no, then you go through some of the conservative management stuff that we'll talk more about in a little bit. After the imaging, if the diagnosis is clear, then you sort of go down this sort of pathway into one of these little boxes for management that are on the slide. However, if things are still not clear after the imaging study, then this is a good time to think about electrodiagnostic testing. Or if you think the patient may have more than one process going on. And then that may lead to a diagnosis, and then you end up in one of the same boxes. If the EMG study is non-diagnostic, then you really have to kind of rethink the whole situation. Maybe you're not dealing with a neurological problem at all. So the differential diagnosis, and when you think about the differential diagnosis for radiculopathy, you always sort of keep in mind some of the red flags that were discussed in our prior talks. So first of all, I mean, could there be an orthopedic issue that is mimicking a radiculopathy? So consider orthopedic issues in the neck, or even more importantly, in the shoulder. And then sort of anatomically, you could have things that push on the neural elements as they leave the chest. So you could be dealing with thoracic outlet syndrome or tumor impingement. Consider infection or infiltrative processes. Again, sarcoid, neoplasm again. or amyloidosis. I just saw a patient who had a progressive brachial plexopathy and it was discovered to be amyloid, and this person has no monoclonal protein on an SPEP-IFE or no light chain abnormalities even, so it can present in very odd ways. Also consider autoimmune entities, including neuralgic amyotrophy, also known as Parsonage-Turner syndrome, also known as idiopathic brachial neuritis. And then there are also some more exotic autoimmune things to consider. Probably in this talk, probably the thing, because the patients that we're sort of talking about are patients with pain and sensory symptoms. So think about at least Lewis-Sumner syndrome, which is a multifocal motor and sensory neuropathy, often with conduction block on electrodiagnostic testing. MMN is a pure motor syndrome, so that's probably more in the differential diagnosis of a patient with, you're concerned about ALS maybe, but that's on the list. A mononeuropathy can also mimic a radiculopathy. You could confuse one for the other, so that should definitely be considered. The examination, it's sort of similar to what I talked about in the other talk that I gave. First, inspection. Again, if the patient has a tilt to the head or a flexed posture or an elevated shoulder, that can be a clue to that diagnosis. Also assess whether or not the posture is consistent throughout the encounter. If the patient does have a tilt to the head or an unusual position, I would probably avoid provocative maneuvers until you image the patient. But those findings would be very concerning, suggestive of fracture or dislocation in the spine. Again, palpation is helpful if there are any muscle spasms or tenderness. That could be a relatively benign thing, such as what we're talking about, a cervical radiculopathy, but it could reflect it could reflect a serious cause of that radiculopathy or some other severe spinal disease process. These patients probably deserve an imaging as well. We talked about the range of motion in the last talk, assessing range of motion in the neck, but the shoulder, I mean, we're not orthopedic surgeons or orthopedic specialists, but we should at least try to be for a little bit and assess the shoulder joint. If there's pain, particularly on passive range of motion of the shoulder, then there's a component of joint, that would suggest a component of joint pathology, and that should be worked up, and that may be the main problem. The Sperling's maneuver is a maneuver that, it involves turning the head to one side, tilting it back, and then the physician places a load on the head, pushing down. And what you're looking for is the patient to report pain in the affected limb. A good positive response would be an electric shock down the arm. If the patient has such a response, then that's quite specific for a cervical radiculopathy. This test overall has a low sensitivity, however. And then the neurological exam should be done, and depending on the findings, you could hopefully develop a diagnostic hypothesis as to which nerve root is damaged. Just as in the lumbar spine, where it's the lower roots that are most affected. In the cervical spine, cervical radiculopathy generally affects the lower cervical nerve roots. In discussing imaging, it's important to keep in mind that, again, the prevalence of asymptomatic degenerative changes are very high, so it's important to treat the patient and not the image. If you're going to do an imaging study for radiculopathy, MRI is the study of choice. It images the soft tissues very well. You can see the neural elements. Generally speaking, gadolinium does not need to be administered unless there's a specific concern about infection or metastasis. Even on a good scanner, for technical reasons, the imaging of the neural foramen can be difficult. And in those cases, it's helpful to get another opinion. I think it can be easy to read sometimes too much into images when we know the clinical information, and it's sometimes helpful to get another opinion from a neuroradiologist. At UCSF, we have a spine conference where cases are presented, and you have sort of a neutral figure give their assessment on the skin. I think that could be very helpful sometimes. If an MRI cannot be done, CT and CT myelography is an alternative. CT scans are so good these days that sometimes I'd say there's probably less of a need for myelography. although it's still done very commonly. And these studies are very good at looking at the bony anatomy, differentiating osteophytes, which sometimes can be really, if they're very slender, it can be basically invisible in MR because they're dark from soft tissue. But obviously you can't really image the soft tissues on CT imaging very well, and certainly you can't see the neural elements. So John discussed an approach to imaging, so I'm not going to go into this a lot, but I just have a screenshot of what we see on our electronic health record. We have an EPIC system, and I imagine if you have EPIC, you have a similar imaging capabilities, and you could put on the same screen your sagittal and axial, and then there's a little button you hit where it will cross-reference the two. And this is very helpful for looking at the neural foramen. And there is a finding on this scan that I'll go into more in a case coming up. But you could look at the various levels and to look for pathology affecting the nerve roots, which could exit here and here. Electrodiagnostic testing. I would say EMG studies, nerve conduction studies in EMGs are good studies for radiculopathy. I would say, we do EMGs. I would say that they are excellent studies for things like carpal tunnel syndrome. Any situation in which you could stimulate on one side of the pathology and record on the other, the testing is very high yield. In this case, the damage is occurring very proximally. We can't stimulate, at least there are techniques for doing it, but they're very difficult anyway with things like needles. And routinely, it's very hard to stimulate proximal to the problem with radiculopathy. So they're good, not great. Dr. Ingsham told me it's an extension of the neurological exam, and that's a good way to think about these studies. So just briefly, when we do motor nerve conduction studies, we stimulate nerve and record over muscle, as many of you know. And then sensory studies, we stimulate nerve and record over nerve. There are also late responses. So F waves, as you may recall, are bounce back signals along the motor pathway. You would think F waves would be very useful in radiculopathy, but the problem is multiple roots innervate every skeletal muscle. So the F waves can pass through sort of the good pathway, even if there are no F waves through the bad route, the signals can go through the good route, and the F waves can look normal. If you're an F wave fetishist, you may notice that there's some chronodispersion of the F waves. So the ones that can kind of get through the disease pathway may be delayed, and you may see sort of a staggering of the F waves. But that's sort of a nuanced detail that may be hard to pick up on. H reflexes are sort of the electrical equivalent of a deep tendon reflex. These are commonly done for the tibial nerve, and it's basically an assessment of the S1 pathway, and they are helpful for S1 root problems. You could argue how much better is it than just checking a reflex in the ankle. That's a debatable point, but those studies are available. So this just shows the setup for a sensory nerve study with a recording electrode here and a stimulator here. This is an antidromic study in a triphasic wave. This is a sensory nerve action potential. So let's say this person has a radiculopathy and there's damage here. So this is the nerve segment between the spinal cord and the DRG. And the patient says, my right foot is numb, but you still get a good signal. Well, how is that possible? Well, when the radiculopathy, as you may remember, it damages this nerve segment, but leaves this nerve segment intact. So basically the nerve is viable, but separated from the central nerve system. So synapses are normal in radiculopathy, and this is a very important principle. This just shows the setup for a motor study and the squiggles we get for a motor study. As I said, whenever you can stimulate proximal lesion, you have a higher yield on electrical testing. We can't really do that in radiculopathy. Nerve studies are generally normal in radiculopathy. If the patient has a C8 problem, you may get a low CMAP and recording over the hypothenar eminence or the thenar eminence, but generally speaking, the nerve studies are normal in cervical radiculopathy. EMG can be helpful, but remember that you really need a disease process that's hitting the motor axons. If it's just affecting the sensory portion of the nerve root, then you won't really see anything. And if it's a demyelinating lesion, you may not see much. You won't see fibs, for example. Still, if a patient comes in with weakness, it's a very powerful test in that circumstance. I mean, you almost certainly you will find out why the patient is weak. It could be all because of suprasegmental factors, but you will answer that question. So these techniques are very powerful in the context of a weak patient, and they're very powerful to investigate alternate diagnoses to radiculopathy. So conservative management, the quality of the evidence here is somewhat limited. I would say a very common practice that has some evidence, but it's sort of largely anecdotal, is to prescribe a short course of steroids. I think John and I both do this, whether it's prednisone or a Medrol dose pack, and it sometimes works. So this is like a week or 10 days, usually without a taper. So that's often done. If there's prominent neuropathic pain, then agents to reduce neuropathic pain are done. Non-steroidal medications. We'll talk more, I think a little bit more about muscle relaxants, but specifically Flexerol has some evidence of efficacy for cervical radiculopathy. The patient should avoid anything that puts a weight on the upper body, basically carrying bags and baggage. Going to a meeting like this would be very bad for those of you with cervical radiculopathy. I hope you have the little wheels on your luggage. Any activity in which there's twisting of the neck would be bad. Swimming, probably not a good thing. I generally often don't recommend a hard or soft collar, although there are some patients that do respond to it, and if a physical therapist does recommend it, I certainly would go along with it. The downside of a collar is that there can be some deconditioning of the muscles in the neck, and sometimes it may be hard to wean the patient off from it. So my bias is not to do it, but it could be done. Earlier, there's a question about cervical traction. I think this sometimes can be helpful, but you want to make sure that the neck is stable before that's prescribed. And usually it's the physical therapist that will prescribe that. And generally speaking, I refer all patients to physical therapy. So this slide shows a couple of studies for physical therapy, and the gist of the studies is what I said in the other talk, in that if there are multiple arms on an intervention for cervical radiculopathy, the arm that includes more therapy and more sort of laying of the hands on the patient and manipulation, generally speaking, that arm wins out on the study. So traction, we already talked about. The evidence is sort of inconclusive, but certainly can be helpful for some patients. I think should be entertained. Again, there's anecdotal success with prednisone, but it's commonly done. And if the patient complains of prominent neuropathic pain, electric shocks, etc., we prescribe the agents that we use for painful polyneuropathy. And then there's specific evidence supporting the use of Flexerol for cervical radiculopathy. That's something that I think maybe we don't think about. We think about it for muscle spasm, but maybe not radicular pain, but there is some evidence to support prescribing that. This slide shows the agents that are often used for neuropathic pain. We both work and live in the Bay Area, so marijuana is often used with or without our suggestion, but many patients do try that, including CBD oil, either orally or topically. In choosing what to use, it's sometimes helpful to look at these sort of blob charts that are mainly in the literature for peripheral neuropathy, pain associated with peripheral neuropathy. And these charts, the size of the blob corresponds to the number of patients that are studied. And then on the bottom is the number needed to treat. So you want a low number needed to treat. That's a better agent. And you can see that the tricyclics, the blob is sort of medium sized, but it has a quite low number needed to treat for neuropathic pain, whereas the gabapentin and pregabalin are not as a higher NNT, but a really big blob. So I think, we use these agents, and Cymbalta, SNRI. Cymbalta is probably maybe a little bit better. We recently were part of a study, a Pete Cori study, in which various agents were tested for idiopathic peripheral neuropathy, painful idiopathic peripheral neuropathy, and Cymbalta was one of the 4 agents, and it did very well in that study, better than Lyrica. So and it's overall fairly well tolerated, so I have to say I do prescribe that a fair amount. If those interventions don't work, then an epidural steroid injection could be tried. These have been performed for a long period of time. Usually a corticosteroid plus an anesthetic are injected together. The techniques and operator skill are very important here, I think critically important. There are multiple people at our institution that do these, including the neuroradiologists do it, people in the pain clinic do it, and then people at our orthopedic institute. And I know John has people that he goes to for this. I have my people, and I just trust them. And some people seem to have a knack for doing this, and other people, practitioners, don't. More than half of the controlled studies have been positive, which is sort of damning with faint praise, because a lot of them are negative. The ones that are positive, about 60% have long-term relief. So there are people that criticize epidural injections, saying they're not efficacious or they don't work very well. And that may be true, but the fact of the matter is when you have a patient with severe neck and arm pain, you got to try something. Even if the chances of success may be less than 50% or 30%, if it's overall a safe intervention, I think it's something that one needs to consider, usually before a surgical intervention, particularly if there are no neurological deficits. All that being said, there are some dangers in doing these injections, and we've seen cases of some very bad outcomes. So this is a scan of somebody before getting a cervical epidural injection, and then they got an injection, and during the injection there was pain, and then after the injection there was weakness and numbness in the legs, and then there's this longitudinally extensive myelopathy here, going from C2 down to C7-ish. So what's going on here? So longitudinally extensive myelopathy and strokes have been described after epidural injections. The literature on this mainly hypothesized, one hypothesis is that there's a needle here that's hitting the spinal cord directly. But I have seen cases in which you get this complication from brachial plexus blocks, which is done in a posterior approach. There's basically no way for the needle, at least in those cases, to hit the spinal cord. My personal suspicion is that that is not a common mechanism. The leading mechanism that's discussed in literature is an intraarterial injection. Basically, some stuff is introduced like particulate matter, and then it embolizes the spinal cord, or the injectant, such as the anesthetic, has a toxic effect on the spinal cord. It basically there's a perfusion of the spinal cord with a very high concentration of a lidocaine. And that may be true, and some of these cases have been associated with the use of particulate glucocorticoids, and there seems to be a clear embolism risk if the practitioner uses that kind of glucocorticoid. But I think another possibility that's often not discussed is that the needle, here's a needle, a small needle, it could maybe inject right into the nerve root. It's important to keep in mind that the nerve and the spinal cord are in continuity, and it is known that if you inject something into the nerve root, that the substances can go both directions and it can go into the spinal cord. And I think some of these cases are probably from an intraneural injection, but it's hard to prove. One way that you can prevent complications is, or at least these terrible complications, is that if the patient really ought to be at least somewhat awake during the procedure, and if there is any pain with the test injection, then the procedure should be either aborted or changed. The procedure shouldn't proceed if there is any pain, any significant flare-up of pain. And these are sort of guidelines that are widely adopted. These procedures should be done under imaging guidance. Test injections should be administered, and particulate glucocorticoids should not be used. Surgery is reasonable when the imaging and the symptom and signs all line up. They should all line up. And it's done for persistent pain despite conservative management for at least 6 weeks, or the presence of a progressive functionally important motor deficit. So these are sort of the guidelines that I think are widely adopted. Now, I would say that there are some patients which you wonder, like, for example, somebody comes in with severe pain and has weakness in their hand, and you see a big disc, and you see them like within 24 hours of the problem. I mean, I think it's a debatable point whether that person should have surgery. On the one hand, if you intervene, you may prevent the transition from a neuropraxia type injury to an axonotmetic injury. The problem is you don't have a crystal ball, so you really don't know how much you're helping the person. But I think with a really acute process, I think there could be a role for intervening very early to try to protect the axons. That's a debatable point. Surgical approaches, well, they're both anterior and posterior approaches. The cervical discectomy and fusion, these can be done, you could do this with and without a fusion. Allows removal, particularly of midline herniations, very well. The risk is the trachea, laryngeal nerve, esophagus, or carotid artery can be injured. But it's generally agreed upon with a midline protrusion that this approach should be done. There are now artificial disc replacements that can be done that have good outcomes. And then if you have a more lateral herniation, a posterior approach can be done. The advantage is you don't risk those anterior neck structures. You can't really get midline pathology. You just can't get that quite as well with the posterior approach. I would say that we, again, have certain surgeons that we work with, and I think some of the surgeons have their preferred approaches, and we generally often defer to what the surgeon wants to do. I don't think we get into the surgical planning very much with our patients. In past years, I had a slide that had a bunch of the trials and it put everybody to sleep. So I just have a summary of sort of the literature here on the surgical interventions. And surgical interventions lead to a rapid improvement in pain level, although generally speaking, the long-term outcomes with surgery are similar to non-operative care. And then all these studies are limited by poor standardization of the non-operative arm. So I have a few cases here. So first is a 39-year-old rheumatologist. So on day one of her presentation, she had some neck strain and then noticed some discomfort when she turned her head to the left. Then pain on looking down. She took some ibuprofen, but things still got worse. She then had radiation of the pain down to the medial arm, forearm, and hand, and it was the worst pain that she had ever experienced. And then she developed hand weakness. Her primary care doctor prescribed her a course of prednisone. And then I saw her maybe about 10 days into it, and on the prednisone, it seemed like things had sort of stabilized. She had pain and limitation of neck flexion. There was no winging of the scapula. The bulk was normal. There were no fasciculations. Her motor exam was notable for mild weakness of the triceps, fairly significant weakness of the finger extensors and the interossei. Curiously, the deep flexion of the little finger, just the little finger, was reduced, but APB was full strength. APB has a lot of T1 in it, by the way. And then the reflex exam was notable for a dropped left finger flexor reflex, and light touch was altered in the medial forearm and medial three fingers, and vibration was down in the little finger. Okay. So this is the same image I had before, and I'm going to turn on the magnifying glass because there is a finding way down near the lower hash marks. There is a disc herniation here, and there's a little fragment here. The light is so bright that, well, I'm below it there. So she had an acute disc herniation with impingement of her C8 nerve root. Oh, there it is. Okay. So then, well, what do you do? Physical therapy, refer to neurosurgery for an anterior approach discectomy, for a posterior decompression or retraction. And I don't think there's a hard and fast right answer. I mean, we referred her to physical therapy. I think if she went to neurosurgery, it probably would be an anterior approach, I think. But her status was very stable when I saw her, so she didn't have a progressive neurological deficit. I did do an EMG study. Now, you could argue, if if you remember the algorithm, you should do that if you don't know what's going on. And I think we were pretty certain what was going on. Although one reason why I did do it in this particular case is the local doctor thought that she had brachial neuritis. So I kind of wanted to try to disprove that. Although sometimes the EMGs of radiculopathy and brachial neuritis can be hard to distinguish. Matter of fact, I think some of our cases of imaging negative radiculopathy are brachial neuritis in which just a single nerve root is affected. But in any case, her nerve studies were completely normal. Her EMG study just showed a mild recruitment of normally configured motor units and some of the weak muscles. There were no fibs, and it seemed like she had a mild right left C radiculopathy. It seemed like a neuropraxic type injury, although this study was done still, I think, about 2 weeks into it, so it could have been a little bit too early for fibrillations to have appeared. And I told her the prognosis, assuming there's nothing new happened, for motor recovery was very, very good. I think we can be very accurate in giving prognostications for motor recovery, because if a patient has MRC 4 minus or better, then you know there's enough of a pool of axons there that just with collateral sprouting, they should have a good, very good motor outcome. I generally don't get into, I generally are very hedgy or reticent to answer questions about sensory recovery. I think, I don't know, John's nodding his head. Because it's hard to predict that, but I think motor recovery, I think we're pretty good at. So the next case, this should actually be case 2, I'm sorry. 41-year-old woman presents with painless wasting of the left hand. She had some neck and left shoulder pain. Okay, that could be a radiculopathy. Her primary care doctor prescribed physical therapy, and the therapist actually brought to her attention that she had wasting of her thenar eminence. And this is her hand here, and there's scalloping of her thenar eminence. And she's sort of thin individual. Her electrical studies, because there was some diagnostic confusion here, so the EMG study makes sense. And there's sort of a funny pattern of findings in that she had low CMAP, so the CMAP was worse for the median nerve, but then the sensory studies were the opposite. They looked normal for the median, and then the ulnar was a low. And then the EMG study showed deinnervation in the muscles on the screen there. So this, just the nerve studies is very classic for a particular entity. So you can sort of, we don't have an audience response system here, but you can sort of ask yourself which is most likely. And it is a cervical rib. And this is true neurologic thoracic outlet syndrome. These patients don't present usually with pain. They present because of painless weakness in the hand. There may be some sensory symptoms, but it's relatively, usually a minor complaint. It's more the wasting and weakness that's the main symptom. And these patients almost always have a cervical rib or at least an elongate C7 transverse process. Though the damage done is not from these bony things, but rather a fibrous band that comes off of these bony structures, which sort of kink the lower trunk. And the T1 fibers, which are more inferior, are particularly damaged, and that's sort of the theory about why the thenar eminence gets particularly wasted, because the APB has a lot of T1 in it. The evaluation is with x-rays, and then we often do MR neurography, particularly in surgical planning. These patients seem to respond to surgery. I mean, the patients that I've seen have been very thankful they've had surgery, even though the wasting may not totally recover, but many of them have, still, I said the pain was relatively less compared to maybe a radiculopathy, but there's still discomfort, and the patients often had report problems with wearing backpacks and so forth, and after the surgery they are less limited, and they're generally quite happy about the outcome. This should be case 3. This is my last case. So a 65-year-old man undergoes C6-7 anterior cervical discectomy with fusion for neck pain with radiation. He had radiation pain in the right upper limb. His exams were not super impressive. He just had a drop right C7 reflex, both in before and after his operation. And then 2 weeks after the procedure, he developed severe right shoulder pain. He presents to the local emergency room, and you hear that there's winging of the right scapula. He can't flex the tip of the right thumb. what is the best explanation? You could think about it, answer in your minds, and then neuritis. So this is brachial neuritis, something that we see all the time, also known as neuralgic amyotrophy. It's a multifocal inflammatory disorder in which sort of named nerve branches get knocked off. With radiculopathy, you don't, with a radiculopathy, at least a single level radiculopathy, you don't get things like a winged scapula or an elevated hemidiaphragm or a very severe involvement of the suprascapular nerve. You see those things in this entity. Triggers include infection, surgery, childbirth, well, not for the men, but childbirth and physical or even mental strain. That's scary. And the recovery, I would say, is generally good. There are different papers have different statements about the prognosis, but I do think that if you wait long enough, most of these patients do recover. And then analgesia is used. If some patients have recurrences of this, and if a patient has had 2 bouts of brachial neuritis, I usually give them a supply of prednisone so that if they get another bout, they can take it right at the very beginning of it. And if the patient comes in very early in the course, I give them prednisone. So prednisone you can use for this and for radiculopathy, so you can cure anything with prednisone. Okay, getting back to the algorithm, so again, neck pain with arm pain, you look for sort of red flags and neurological deficits, and if you have any of those things, you do an imaging study. If you know then what's going on, then you go into the treatment boxes. If you don't know what's going on after the imaging study, then that's when electrodiagnostic testing can be helpful. And that's the end of this talk. Thank you for your attention.